Hello, everyone, and welcome to Heads Up, the weekly podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation, and chronic daily migraine survivor. I am here with Dr. Vincent Martin, MD. He is the director of the Headache and Facial Pain Center at University of Cincinnati, and he is the president of the National Headache Foundation. Hello, Dr. Martin. How are you tonight?
Good. How are you?
Good. We have an awesome topic today. Our topic is something that everyone thinks about all the time. We think about rebound headache. We think about whether we have it, whether we should take our medications because we're worried about it. Our doctors talk about it. It's a little bit controversial. So let's dive right in and chat about it. All right, so let's start by just defining rebound headache. What is it?
Well, rebound headache is what we call medication overuse headache, or the short term for it is MOH.
Right.
And generally what happens is you have to be overusing your acute medication. So an acute medication is something you take to treat your headaches. So as a general rule, we say that if people are overusing their acute medication more than a couple days a week,
right,
then that is probably, we believe, too much. And if they have that along with 15 or more days with headache, then they could meet the criteria for medication overuse. So basically you need two things. You need to overuse the meds, and there needs to be some sort of progression of your headaches worsening with the medication overuse.
Okay. So what are some of the contributors? What are some of the main medications that are associated with rebound headache or medication overuse headache?
Well, not all medications are created equal. What that means is that medications particularly like narcotics, those are like controlled substances, like things like, hydrocodone and morphine and oxycodone and so forth. So narcotics and another medications called that have butalbital and caffeine in particular. And the trade names for those, the non-generic names, are things like Furanol and Furosed. So those two groups of meds, the butalbital containing meds, narcotics, seem to have a greater likelihood of having rebound headaches than other meds. But even things like the triptans, which the triptans are the class that includes things like Emitrax and Zomig and Maxil and so forth, if overused, at least we believe, can cause rebound headaches as well. Anti-inflammatories probably are less likely to do it, such as ibuprofen and naproxen and so forth. But if the anti-inflammatory is combined with caffeine, and there's a variety of different products that have that, that's another group of meds that are probably have a high likelihood of having medication overuse headaches, or what lay people call rebound headaches.
Okay, so narcotics, triptans, and possibly anti-inflammatories, especially if combined with caffeine.
Yes.
Okay. So here's a good question. How do I know if I'm experiencing rebound headache, especially if I'm someone that gets headaches, nearly every day?
Well, I think we talked about it briefly before. So you have to have 15 or more headache days per month, and then you have to you meet certain criteria. I mentioned kind of this generic, 2 days per week. If you look at the official criteria, they actually have different cut points for like anti-inflammatories and for triptans and so forth. But I think the 2 day per week thing is kind of a nice thing for patients to remember.
Okay. So this is an important question, I think, for people to know, because it varies based on the type of medicine, and it could be dangerous. How do you get people off their medications?
Well, there's a lot of different ways. One way is that you could slowly taper them off. Okay. So if you have somebody taking like, say, 4 or 5, pills per day, maybe you go down to, 4 pills per day for a week and 3 per day for a week, and et cetera. So it may take, 4 or 5 weeks to get the person off the medication. Right. Another option would be to abruptly withdraw them, which is a little bit more traumatic, because all of a sudden you're taking, a certain number of pills, most days, and then all of a sudden you just abruptly stop them. Most people will say, well, what do I do when I get a headache in that situation? So you oftentimes have to give them another alternative. Something we commonly use is something called intramuscular ketorolac, which is a shot that we give a couple days a week to kind of, for the really severe headaches, to kind of give them something that they could take, assuming they don't have any allergies to that medication, to kind of get them off. And another approach, if you want to abruptly withdraw them, would be to hospitalize them. And you
Right.
could give people intravenous medications for anywhere from 3 to 5 days, and abruptly withdraw the medication, and then get them off that way. That option is probably only available in a few headache centers that actually do inpatient management.
Okay. All right. So you can taper, or you can also, do an abrupt stop, and you can also be hospitalized if that's available or if it's necessary. So are there negative repercussions to delaying taking our medicines because we're afraid of getting rebound headaches?
Well, I think that there could be. It's kind of like you want to use your abortives early
Right.
because you're going to respond better, but don't overuse them too much because
Right.
they kind of tip the apple cart and cause people to actually get worse.
It's a real conundrum. It's like this, you're in pain and it's this decision you have to make.
Well, I hear it all the time because you'll tell people, well, you need to start decreasing your meds, and they're like, well, what am I going to take for my pain?
Yeah.
So what we try to do is work on other techniques for managing pain that don't involve taking pills.
Hmm.
So one would be like teaching them how to relax and do biofeedback and relaxation techniques,
Hmm.
so forth. In some cases, we might do acupuncture, some sort of other behavioral
Hmm.
therapies. We might do biofeedback. So there's a lot of different things that one might try to give them other alternatives. And the big
Yeah.
thing is these patients need to be empowered themselves,
Yes.
because when a patient comes in and they're not doing well and they're overusing their meds, what I often tell them is I say, look, only half of you getting better is me.
Hmm.
The other half is you.
Yes.
There's a lot of things that you could be doing in your life that might not be favorable for headaches. Like you might be drinking too much caffeine. You might be in a very stressful life situation or a very stressful work situation.
Hmm.
And sometimes if you don't work to resolve these other issues, then the headaches may not always improve. So there's a lot of things that patients have to do. They have to stay hydrated. They
Hmm.
need to eat regularly. They need to eat the proper types of food and so forth. So it's a whole multi modality treatment for these people to get them better. But when they actually get better, they're really empowered, and they really feel like they can have control over their headaches. But
Right.
it's not easy. And I think that's one reason why
Yep.
seeing people in a headache clinic makes a lot of sense.
Yeah. Okay, that was a great topic. I think that I see so many people that ask about this and wonder about this all the time. So I hope that helped a lot of people. Is there anything you would like to add on the topic of rebound headache?
Well, I would just say that, from a physician standpoint, you have to try to have some sympathy for people that are overusing meds, because
Mhm.
a lot of times some physicians may stigmatize the patient, and that they may kind of blame the patient for overusing meds. But I think if I had to guess, I would think that in many instances it's the headaches driving the medication overuse, as opposed to the opposite,
Yeah.
meaning the medication overuse driving the headaches. But clearly there is some balance to this whole situation, is that if you're overusing narcotic meds or butalbital containing meds, then they may be driving some of your headaches, and even triptans in some instances as well. So
Mhm.
there's a balancing act. And I would argue that even if the meds, even if it was the headaches driving the medication overuse, it still would be a good thing to get people down on their medications, because
Right.
you really don't know what, using these meds daily or 15 or more days a month really has on your body. So I think the end goal is to try to use as little medication as you can get away with.
Right. Very good advice. All right. Well, thank you, Dr. Martin, and thank you everyone for watching tonight. And we will see you next week on Heads Up, the weekly podcast of the National Headache Foundation. Good night.